Our next speaker is the Deputy Executive Director of Nursing Services at the National Kidney and Transplant Institute. She is one of the most iconic women in Quezon City for 2021, given by Quezon City Tourism Department during the Women's Month celebration. In 2019, she is among the 100 most influential Filipino women in the world at the Innovator and Thought Leader category, awarded by Filipina Women's Network at its Global Summit in Westin Plaza, Paris Vendome Hotel, Paris, France. In 2017, she had numerous awards received, such as Best in Public Image Award, Best in Vocational Service Award, Best in Economic and Community Development Award, Outstanding Project in Literacy and Basic Education Award, Outstanding Project in Maternal and Health Award, and Best in Rotary Club Fellowship Award. Dr. GERIAL earned her bachelor's degree in nursing at the St. Jude College and postgraduate Master of Hospital Administration at the University of the Philippines, and Doctorate of Philosophy in Nursing Education, major in Leadership and Management at the St. Paul University, Manila. She is also the founding president of Urologic Nurses Association of the Philippines, vice president of the Association of Nursing Service Administrators of the Philippines, vice president of the Department of Health Chief Nurses Association (NCR), and a co-founder and chief finance officer of Health Educators, Advocate and Leaders in the Philippines. She is a fellow of Association of Nursing Services Administrators of the Philippines, fellow of Philippine Society for Quality in Healthcare, fellow of Philippine College of Hospital Administrators, and an all-star president, Rotary Club of Chinatown Circle, last 2016 and 2017. Our next speaker, let us now welcome Dr. Nerissa V. MENDOZA-GERIAL.
Good day to all of you. To Dr. Paul Nimrod Firaza, the course director of this postgraduate course, and Dr. Rodrigo Hipol, the president of the PUA Mindanao chapter, and to all our online participants, it's an honor to join you here in this webinar. Again, I am Nerissa M. GERIAL, the Deputy Executive Director for Nursing Services of the National Kidney and Transplant Institute, and the founding president of Urologic Nurses Association of the Philippines, or URANAP. And I will be discussing about the essential healthcare services in the face of COVID-19 pandemic, the NKTI experience. Today, I will be discussing about the following topics: the hospital readiness checklist for COVID-19 from the World Health Organization, and I will share the NKTI experiences, workflow, and process changes during the pandemic. The current health crisis has challenged all sectors in the community, most especially the healthcare system in the country. Well, just to go back, the outbreak of a novel coronavirus disease in Wuhan, China, in December 2019 marked the beginning of unprecedented global spread of the disease, leading to a near collapse of the healthcare system in most affected countries. Well, I can say that the resilience of the health systems in response to COVID-19, including those in high-income countries, were all tested. Now, the question is, how did the healthcare system in our country cope with the COVID-19 pandemic? More than a year after the first COVID-19 case in the Philippines was recorded, globally, we have more than 160 million recorded cases, and in the Philippines, we have surpassed the 1 million mark for confirmed cases. Hospitals play a key role in providing health services and essential medical care within health systems. This role is particularly prominent during crisis. Many hospitals normally operate at near surge capacity, and so just a small rise in patient numbers during an emergency can pressure hospitals to work beyond their functional capabilities. The progressive spread of coronavirus disease during an outbreak can overwhelm hospitals' ability to respond, as there are simply too many patients needing medical care at the same time. Hospitals need to consider their readiness to cope with the influx of patients and increased need for medical services in times of crisis. They should prioritize and implement actions specified in their emergency preparedness plans for biological threats, specifically threats that may cause severe acute respiratory illness, in order to identify suspected cases, limit transmission within the facility, and provide medical care. This includes activating protocols and procedures. Specifically in safe physical spaces, emphasizing isolation measures, we need to assess our areas in the hospitals and if we have adequate isolation rooms. The education and training of our personnel is also very important. For example, in this situation, we need to teach them how to use the personal protective equipment or the PPEs and monitor them also if they're following the protocol. Regarding patient management, do we have enough knowledge in handling probable, suspected, and confirmed cases? And also sample collection and handling and disposal of hazardous biological waste. The benefits of an effective hospital-based response include continuity of essential services, well-coordinated implementation of a priority action, clear and accurate internal and external communication, swift adaptation to increased demands, effective use of scarce resources, and a safe environment for health workers. If we know what to do, especially in times of emergency or disaster, if you have a policy or protocol, if the people are trained and they know what to do, it will be easier for everybody to attend to the situation. For example, since we always have leptospirosis every year here in NKTI, we already made a leptospirosis manual to serve as guide for the new staff on what to do, what equipment or what supplies to prepare and others. We also made a COVID manual last year and all departments contributed to that, and we are now doing the second edition. The World Health Organization has also created a hospital readiness checklist for COVID-19. The checklist has been developed to support hospital preparedness and response for the management of COVID-19 cases. The elements described in the list may not apply to all hospitals and may need to be adapted to the specific characteristics of each hospital because some have different policies. So you can also look at the WHO checklist and use it as guide in making your own policies and protocols. These are the elements in the checklist to be assessed as we respond to the COVID-19 crisis. And it's divided into the following areas. First is leadership and coordination. Well, there should be a point person in every department to ensure that all plans and guidelines can be carried out to all levels of employees for operational support, logistics, and supply management. Another is in times of crisis, information and communication. Cascading of relevant information is very crucial to a successful crisis response. The next one is very important, human resources. Well, we all know that shortage of manpower has been a problem long before the pandemic started. We are very much in need of nurses and doctors. and other allied healthcare professionals. So it is very important that we have a contingency plan to address this concern. Aside from that, we should also assess the continuity of essential services and surge capacity. It can help to, alert the leaders and other authorities about where service delivery and utilization may require modification and investment, and would eventually help to maintain the provision of essential health services. Rapid identification diagnosis is also significant due to increasing outbreak of COVID-19. The early diagnosis of patients is crucial for prompt and effective prevention and control. Isolation and case management and infection prevention and control should also be in place to effectively respond to crisis. Since most of the hospitals in the Philippines are implementing almost the same protocols and guidelines, I shall tell you about the ones being implemented in our hospital, the National Kidney and Transplant Institute. Let me give you a little background about the NKTI. Well, NKTI is a tertiary specialty center for renal health and Asia's leading kidney and transplant center. We are also known for advanced patient care provided by its medical and nursing staff, particularly the treatment of renal diseases, dialysis, and organ transplantation. Well, in the Philippines, one of the top hospitals catering to patients, most especially renal cases, amidst this crisis is the National Kidney and Transplant Institute. In truth, nobody was ever prepared for this war. So how did the staff prepare themselves for the impact of COVID-19? Due to the rising COVID-19 cases, the management has set up precautionary measures for the immunocompromised patients of the Institute. With a prompt action from the different departments and in coordination with private and government agencies and even the non-governmental organization, including the UNICEF and the Red Cross, tents were set up outside the emergency room to accommodate probable cases and await results of their swab tests. With this, the medical staff can receive those patients at the tent, and they no longer have to bring them inside the emergency room, protecting the patients with kidney problems, mostly elderly patients who are having dialysis treatment, and post-transplantation, as they are one of those who are most susceptible to the disease. Patient cohorting was used to reduce the potential for cross-infection between patients and healthcare workers. So we have a tent for patients who are intubated, tent for hemodialysis patients, another tent for those awaiting lab results, and others. Here are some photos of the tents that we were able to set up at the start of the COVID-19 to accommodate our patients. These are also the tents set up in other hospitals such as the PGH and the RITM. Here are some of the policies and protocols implemented in our institution, basing on the guidelines set by the Department of Health, Centers for Disease Control, and of course, the World Health Organization. The nursing services, in coordination with the Infection Prevention and Control Committee, has conducted trainings for the NKTI staff for proper donning and doffing of PPE. And of course, the infection control measures to help protect the patients by performing procedures according to best practices and be continually equipped as NKTI opens door to care for COVID suspects with renal comorbidities. The practice of physical distancing and hand washing was overly emphasized, as these are the two of the most effective ways to prevent the spread of COVID-19. So, what are some practices of infection control being done in the COVID battlefield, and how are they being done properly? To ensure the safety of healthcare workers, most especially the hospitals in the Metro Manila and in NKTI have created the PPE safety officer role. So I know that all of us have patient safety officers. So the safety officer leads, protects, and guides through the processes of safely and correctly donning and doffing of PPEs. The PPE safety officer will be able to answer questions and give reassurance to staff that they are doing the right thing. It also gives confidence to colleagues that their safety now is the highest priority. So, in other words, the safety officer are responsible for monitoring compliance with PPE protocols, support the donning and doffing procedure going through a stepwise checklist, guiding, correcting, and assisting during donning and doffing, and also anticipating and planning for risk. Of course, prior to being assigned at the COVID tents, one must first protect oneself with the use of PPEs. We all know that PPE is a main source of protection for hospital staff, especially for those handling confirmed COVID positive patients. All personal protective equipment should be safely designed and constructed and should be maintained in a clean and reliable fashion. So it should fit comfortably, although we all know that wearing of the N95 and respirator mask for long hours can be very uncomfortable for our healthcare workers. So if the personal protective equipment does not fit properly, it can make the difference between being safely covered or dangerously exposed. Moving on, let's discuss about the process in the new triage consultation tent in NKTI. When a patient seeks consult at the ER, they will be initially screened at the ER triage tent. Majority of the hospitals have triage tents, including those in the provinces. So patient's chief complaint will be initially assessed by the triage nurse. Initial vital signs will also be taken. So once assessed, the triage nurse will endorse the patient to the concerned triage doctor on duty. The triage doctor now will do the assessment. For urgent medical needs, medical management will be administered at the triage area, and patient will be initially classified as probable or suspected case. For patients who come in due to severe respiratory distress, patient will be immediately transferred to the resuscitation area. So personal information and history will be obtained from a reliable companion while patient is being managed at the resuscitation area. So if the patient is stable, the triage nurse will facilitate the ordered diagnostic requests and laboratory workups. So all patients admitted in the ER will be swabbed to identify proper room or unit assignment. If patient requires admission and cleared as probable case, patient will be admitted to the ward. So we have designated wards for patients with pneumonia, and we also have wards for COVID positive patients. If the wards are full, patients will stay in their assigned tents in the ER or may be transferred to other COVID designated hospitals like Intala, RITM, PGH, or the Lung Center of the Philippines. In the ER tents, patients are already screened to determine the case prioritization and COVID stratification, whether they are pay or a charity case. We also do cohorting of patients in the hemodialysis units. As seen in the slides, we have identified specific areas for negative and confirmed cases. We put our COVID negative hemodialysis outpatients at our annex building and the COVID negative hemodialysis inpatient in our main building. So we have a separate area for COVID negative who will be needing hemodialysis. For COVID positive patients, we have a designated area also located, as I've said a while ago, in the main building where they are dialyzed. As you can see in the slides, we have 30 machines plus 15, so plus 6. So a total of 51 stations for COVID negative and now a total of 16 stations for COVID positive patients. So during the start of the pandemic, we also have one big tent for hemodialysis patients. Well, aside from the existing hemodialysis facility of NKTI, recently we opened the modular hemodialysis facility for COVID-19 patients with a total of 20-bed capacity because of the increased number of patients needing dialysis, and some centers here in Manila have already closed and some are already full. So last May 2021, we did a short opening ceremony with DOH Secretary Francisco Duque, as you can see in the slides, Presidential Spokesperson Harry Roque, our IATF Chief Implementer and Vaccine Czar Secretary Carlito Galvez, DPWH Secretary Mark Villar, Quezon City Mayor Joy Belmonte, and also our partner, Debron Philippines. These are some photos of the modular hemodialysis facility that was built in the garden of NKTI. Also, a modular dormitory was built beside the modular hemodialysis facility for the healthcare workers that would be assigned there. So the dormitory has a 32-bed capacity. So let's go now to our critical units. In our hospital, we only have ICU and IMCU. Other hospitals have CICU, PICU, NICU. But let me share with you how we facilitate admission of suspected and confirmed cases at our intermediate care unit. General guidelines. The intermediate care unit is a designated unit for critically ill COVID positive patients. And the critically ill negative patients are at the intensive care unit. The patients there are endorsed from ER or from the ward. So just like the other areas, there is also a designated area for donning and doffing at the intermediate care unit. And there is also a designated safety officer every shift to check if the staff are following the set guidelines of the hospital. Visitation privileges is suspended for suspected and COVID positive patients, not only in the IMCU, but also in the designated COVID units. However, the nearest of kin or the authorized representative shall be required to be available for regular patient updates or any decision that has to be made for patient management. Next is all soiled PPEs shall be placed in double yellow bags to make sure that the staff who will be collecting it will not be infected. And once room is vacated, it shall undergo a terminal cleaning. After terminal cleaning, UV disinfection shall be facilitated. Those guidelines on waste collection and disinfection of rooms in the IMCU or ICU are also being followed in the other patient care areas of the institute. Well, moving forward, we also have our processes and guidelines in our COVID wards, or as we call it, our hot zone. We have 4 wards in the second floor of the main building. that is Ward 2A, 2B, 2C, and 2D. We designated all those wards for COVID positive patients. So I want you to imagine our 4 wards. The point of entry is our Unit 2A. Unit 2A is a designated donning and entry area of doctors, nurses, and other allied health staff who are attending to patients. There is also a designated safety officer at the donning area. Now, for the point of exit, Unit 2D is the designated doffing and exit area. There is also a designated safety officer at the doffing area to monitor compliance with PPE protocol. All patients from the hot zone shall be transported with an aerosol box. It shall be used and brought back to the unit and disinfected after use. So when a patient room is for UV disinfection, the aerosol box shall be placed there for decontamination, including the chart holder. When transporting a patient out from the COVID area or the hot zone, because they are considered dirty, the transport team shall don a new level 4 PPE with the word clean placed on the left upper part of the front of the coveralls. That is why they need to change and observe safety protocol. Then, the transport team may go back to the hot zone wearing the same PPE. Well, during this pandemic, we implemented the modified functional nursing delivery care system in the COVID areas. There are designated nurses who will only work at the bedside. And there are designated also charge nurses who will stay in the nurses station just to receive, carry out, and relay doctor's order to the bedside nurses. The main purpose of this setup is to minimize cross-contamination, and they are not allowed to cross over their designated areas of assignment. Let's go now to the operating room. Well, we all know that the worldwide spread of COVID-19 has led to a near total stop of non-urgent and elective surgeries across all specialties in most affected countries. Well, according to the study published in the British Journal of Surgery, each additional week of disruption to hospital services will be associated with a further 2.4 million cancellations. So during the start of the pandemic, an important question that is unanswered is when and how should elective procedures be scheduled again? And what kind of organizational changes are necessary to protect the patients and also the healthcare workers when clinics and practices reopen? Well, the transmission of the virulence of this new pathogen has raised concern for how best to protect the operating room staff while effectively providing care to the infected patient requiring urgent or emergency surgery. So initially, all elective surgeries here were put on hold, including kidney transplantation, as the Institute created guidelines and protocols as precautions for both the operating room team members and patients. We also benchmark practices and at the same time aligned it with the international guidelines as we gradually accept patients giving priority to renal cases. Well, these are some of our policies and protocols that we have established, which I believe is also similar to the practices of other hospitals. To prevent inconsistencies in PPE donning guidelines, all other medical and paramedical staff going inside the ORRR complex shall comply with the donning guidelines based on the prescribed PPE worn per case or per procedure. So the COVID-19 wards and operating rooms require the most protection for personnel. This applies to all personnel in the areas where confirmed cases of COVID-19 are admitted. So They include healthcare workers who have to stay in these areas for at least 4 hours, and the anesthesiologist who intubate patients and stay for an entire operation. So level 4 PPE is recommended for patients with positive RT PCR tests. If the patient for surgery is negative for RT PCR test and result is within 5 days, the surgical team may opt to downgrade to the use of level 3 PPE. If test result was made more than 5 days from surgery, a repeat RT PCR test is needed. Next is prioritization and scheduling of cases. Hospitals should establish a prioritization policy committee consisting, of course, of surgery, anesthesia, and nursing leadership to develop a prioritization strategy appropriate to the immediate patient's needs. In our institute, only emergency and urgent renal, urologic, and vascular cases and pre-scheduled kidney transplantation and those whose requirements are met were scheduled for surgery during the first months of the pandemic. In other words, we only do urgent and emergency cases. As we gradually resumed our services, when we schedule and prioritize surgery, some of the factors that we account for are list of previously canceled and postponed cases, and specialties prioritization like the cancer and organ transplants. So we started to accept elective cases during the latter part of the 2020 until this month. So unfortunately, due to the increasing number of cases, the management decided to suspend again elective cases and to prioritize only the emergency and urgent cases. Now, we are gradually accepting again elective cases. Other things to account for are identification of essential healthcare professionals. Do you have enough surgeons, anesthesiologists, nursing staff, and technicians per procedure? Because of this virus that affected the operations in the OR, you should also have strategies for phased opening of the operating rooms. In our hospital, surgical procedures will only proceed if all requirements are met based on the guidelines for the new normal hospital operations. So before the pandemic, we are doing kidney transplantation operations almost every day. And we gradually resume kidney transplantation surgeries now for 2 to 3 times a week. We also have room designation where all surgeries of suspected or confirmed 19 patients were assigned to be performed in a dedicated rooms so as to avoid patient and OR cross-contamination. So as you can see in this slide, our room designation in our hospital. COVID suspects or probable cases, patients with infectious cases, patient awaiting RT PCR result should also have designated rooms. So we put up an OR satellite near the emergency room where minor and major operations of COVID positive patients are being performed. So this is outside the main OR building so as to prevent cross-contamination with our clean cases. Another recommendation is the OR complex traffic flow. There should be an established separate pathways to keep suspected or infected patients apart from non-COVID ones, protecting not only the patient but the healthcare workers as well. So in transit, surgical patients proceeding must not stop in any other place other than the COVID dedicated operating room, or they must be taken directly to a designated operating room that must be adequately marked with clearly visible door signs. Patient transit to and from the COVID operating areas must be as quick as possible. A predefined direct path must be kept as short as possible and away from other patients and people in general within the hospital in order to minimize the chances of infection. The operating rooms are equipped with high-efficiency particulate air or the HEPA filters and undergo ultraviolet light disinfection either every after procedure or at the end of the day. So transport equipment like the stretchers, the wheelchairs, and other equipment are sanitized before and after use. So this is also the same with the other areas. Surgical instruments are routinely sterilized. There is also a regular disinfection of frequently touched areas such as the elevator buttons, railings, countertops, and doorknobs. There is also a scheduled wall-to-wall disinfection of hallways and corridors. Well, despite the current trends, RT PCR test still remains as a requirement for all patients prior to admission and to employees or healthcare workers, especially those in the critical areas for healthcare monitoring. Initially, the staff directly assigned in the COVID areas were swabbed every 2 weeks. Thereafter, guidelines were revised, and instead of every 2 weeks swabbing of employees, it was done on a monthly basis. While the other employees not directly rendering care to COVID positive patients are swab symptom based. Well, in the latest Department of Health memorandum, as you can see in the slide, regarding the interim guidelines on prevention, detection, isolation, and treatment, and reintegration strategies for COVID-19 cases were updated as follows. For asymptomatic, the duration of isolation is at least 10 days from date of specimen collection. With mild symptoms, at least 10 days of isolation from the onset of illness, inclusive of 3 days being clinically recovered. And with moderate to severe case, at least 21 days of isolation, inclusive of 3 days being clinically recovered. Now, I would like to share with you some of what my staff have experienced on the battlefield against the coronavirus. So, when the pandemic hit the borders of the country last March, nurses were called to serve our countrymen, and each had to leave their families in order to care for the sick and affected. With a shortage of nurses in the Philippines implying a stage of havoc and disarray for the medical system, especially in the current situation of the country, hospitals still manage to have its spirited and strong-willed nurses fight a war they were not prepared for. Because we all know that they're with a patient 24 hours a day, 7 days a week. So in our institute, the NKTI, the nursing workforce serve as the backbone on the front lines of fighting against the invisible adversary, the COVID-19. So I do believe that we empower each other by being connected to one another, communicating our needs and differences, and showing camaraderie every step of the way. Yes, I can tell you that there are staff issues also because they are afraid, they are anxious, but we make sure that the leaders are there to support them and help them along the way. At the start of the pandemic, nursing staff have been working for long, grueling hours, finding themselves risking their lives every day. In NKTI, there are certain practices that are enhanced and modified in order to care for those affected by the virus. Well, the nursing services, in coordination with the Infection Prevention and Control Committee, has conducted trainings for the nursing staff, or as I've said a while ago, for the proper donning and doffing of PPEs, and infection control measures to to help protect patients by performing procedures according to best practices, and be continually equipped as NKTI opens door to care for COVID suspects with renal comorbidities. The practice of physical distancing and hand washing was overly emphasized to the nursing staff, as these are the two of the most effective ways to prevent the spread of the virus. So I know that most of the hospitals are doing the same. Along with the increasing number of COVID-19 cases worldwide, came also the global shortage of PPEs and other necessary supplies. Safety concerns are high given the dearth of protective equipment. Nevertheless, with the endless support from both the private and public sectors and others who are willingly share in the spirit of what we call bayanihan, donations and help for our frontliners are coming from all parts of the region. So it is good to know that it is easier to acquire PPEs now, unlike during the start of the pandemic, where most of our PPEs came from donations from different local and private organizations and even individuals. Well, in our efforts to combat the current health crisis, the Philippine government has procured vaccines from China, UK, USA, and Russia. The rollout of vaccines, given the limited global supply, shall be based on a prioritization framework to ensure that those who have the highest risk exposure will be protected from the disease. So just to show to you, this is the NKTI COVID-19 Vaccination Team 2021. So the COVID-19 vaccine rollout last March 1, 2021 marked a historic event as the government began its biggest vaccination-driven in scale following the receipt of 600,000 donated CoronaVac doses. So on the first day of the rollout, at least 756 frontline healthcare workers from 6 hospitals in Metro Manila received the Sinovac CoronaVac, with PGH Chief Dr. Gerardo Legaspi being first to be inoculated in the country. Well, I was also able to take part in this historic milestone in our country as a nurse wife who vaccinated her doctor husband. So this was also featured in TV Patrol, Rappler, Manila Times, and nurseupdates.com. Along with the nursing leaders, we continue to conduct leadership meetings to constantly plan and address concerns arising both in the administrative and even in the clinical areas. So schedules were really strategized in a way that the staff will be able to prepare, have ample time to rest, and regain strength before coming back to the battlefield stronger than ever. So just to let you know, it was in mid-March when those affected by the outbreak started swarming in hospitals. So NKTI, being the premier hospital catering to renal patients, then accepted cases with renal complications. So the nursing staff were at first really overwhelmed, given that most did not anticipate the burgeoning of cases in the Philippines. But eventually, you know, over time, they were able to find ways to cope with the hard reality that every person is really battling. Well, because of this, when I heard about their being discriminated or being driven away by their landlords in their communities and barangays, I personally wrote a message of hope addressed not only to the healthcare workers, but to the community as a whole. And I'm glad that it was published by Nurse Updates, but it was also shared by Rappler, Inquirer, Manila Times, Daily Tribune, Metro News Central, Go Cavite, Go Batangas, FB page, and other media, social media platforms. So aside from that, I being their mother in the nursing services, I wrote a letter to all my more than 800 staff, giving them hope and encouragement saying, kamusta ka, mag-ingat ka, sampu ng iyong pamilya. Well, it is my way of reaching out to them, as I cannot personally talk to them every day. I wanted them, to feel that they are valued, and the whole institute remembers and appreciated their sacrifices. NKTI was not immune to the virus, and several of my staff tested positive. I think more than 200 plus of my staff got positive. With this, I felt the need to write them another letter stating that I am with them and that they are in my prayers. Well, it is the nurses' appeal to the society whom they are serving that they be treated with respect and sympathy and not be treated as outcast by being disease carriers. The nursing personnel, sincerely appreciate the empathetic citizens who have volunteered in donating whatever they have to help, from the meals given down to the PPEs in any form, and even prayers offered every day. Well, these things help them realize that they're not alone in this battle. These things give them courage to continue in the fight of serving the Filipinos in this COVID war until we win it. So, my dear doctors and my colleagues in the nursing profession, I just want to inform you that there is pain for leaders too. It's no easy job to be a leader. What the staff is experiencing can also be felt by the leader. Every time, I just want to share this with you, every time I talk to my staff and hear them cry, I feel their pain. Especially if they will say, Ma'am, paano na po ang pamilya ko ngayon nag-COVID positive ako? Paano na po ang mga anak ko? Masaswab din po ba sila? Saan po ako titira? Maliit lang po ang bahay namin, iisa lang po ang kwarto. Natatakot po ako. Ano po ang gagawin ko? Well, hearing those words breaks my heart because I know that I cannot cure them of their infection. But what I can give them is my support, prayers, and concern. It's good that, the government and other private sectors are helping us provide accommodation and transportation for our healthcare workers. If the COVID positive staff cannot quarantine at home, we have a partner hotel where they can stay. Those who cannot go home because of transportation problem, we also have an accommodation facility for them. And we truly thank those who are helping our healthcare workers. Above all else, the biggest and perhaps the hardest sacrifice a healthcare worker can possibly give would have to be the time spent away from their families and loved ones in this time of crisis. These sacrifices are the realities lived by the people nowadays. Through this, they are able to save lives, even if it means putting their own at risk. I know that no monetary or other incentives could compensate to the work and sacrifices of our healthcare workers. But I believe that we are tirelessly working because the nurses, the doctors, like the rest of the frontliners, are aware of their chosen profession and the risk that goes with it. And we have pledged to do our duties no matter what. So it is our passion and our calling to serve the Filipino people during these trying times. Every day, we are faced with the threat of COVID-19. That is why I would like to give credit to all our healthcare workers, our doctors, our nurses, the medtechs, and other frontliners in the hospital on how resilient they have become, despite the impact of this crisis, both physically and psychologically. We all hope for an end and cure to this disease, and the world continues to adapt to the changes that needs to be done to achieve this. Before I end my lecture, I would like to say to all of you, we are not blessed because everything went right. We are blessed because we got the fight. Thank you and keep safe.